Welcome, everybody, to Live Your Best Life, the Benefits of Palliative Care. During this seminar, all participants will be in a listen-only mode, and there will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. Please remember that information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild, and I am the Executive Director at the LifeRaft Group, and I would like to introduce our presenter for today. Dr. Grant Smith is a palliative care physician and clinical associate professor of medicine at the Stanford School of Medicine. He is the medical director of the Stanford Palliative Care Community Partnerships team. He received his medical degree from Harvard Medical School and completed his residency in internal medicine and fellowship in hospice and palliative medicine at the University of California, San Francisco. As part of the Stanford faculty, he is an attending physician on the palliative care inpatient service and in the outpatient palliative care clinic in Palo Alto. And we're really looking forward to his presentation today. And you can go ahead and proceed, Dr. Smith.
Great. Well, thank you so much, Sarah, for inviting me today, and thank you to the LifeRaft group. It's really a pleasure and privilege to get to be here, and really excited to share with you some more information about palliative care and how it can help folks to really live their best. So I'm just going to share my slides here. And welcome again for everyone who's coming today. I know that showing up for a talk that has palliative care in its name can sometimes be a little bit intimidating, but I really hope by the end of the session today that you know a little bit more about palliative care. It doesn't feel quite so intimidating, and hopefully you can learn how it might be beneficial for you or your loved ones or family members. So we've titled this talk Live or Living Your Best Life. And when I think about like, what does that mean to sort of live my best? Sometimes I think about things that are pictured here. You know, eating meals with family. Pizza is pretty high up on my list of things that make life good. Spending time with family and friends, going to kids or loved ones' sporting events, being out in nature. Maybe there are things not pictured here that are also important, like participating in our spiritual, religious, or church lives, taking care of pets, taking care of loved ones, our occupation, our jobs are all parts that make life worth living and make life sweet and enjoyable. And as a physician, I know that being sick or having an illness can really take you out of enjoying those aspects of life that are meaningful and that provide joy. And today we're going to be talking about how palliative care is really a field that really aims to try to help people get back to enjoying life as much as possible and focusing on those things that bring joy and bring meaning to life, despite what's going on with an underlying health condition. So as we talk about this today, we're going to be trying to answer some of these questions. You know, what is palliative care? How is it different from other parts of medicine that maybe you've experienced or are used to? When and how can someone benefit from palliative care? We'll talk about how does it actually help people to live better? And then I'll spend a little bit of time talking about how palliative care is different from hospice, which is sometimes closely associated, but not exactly the same as palliative care. Again, we really welcome questions, so please, as questions come up, feel free to put them in the Q&A. Some of my colleagues have joined us today, and so they may be responding to some of the questions in the Q&A, but we'll also highlight questions at the end live as well. So let's start with this question. What is this thing called palliative care? And throughout the presentation today, we're going to be using a case for Mrs. Jones to help illustrate what palliative care is and how it might help someone who's living with a diagnosis. So let's start by meeting Mrs. Jones. And she is a 74-year-old woman who has been diagnosed with a metastatic form of gastrointestinal stromal tumor, or GIST, about 5 years ago. She's been taking imatinib or Gleevec, one of the tyrosine kinase inhibitors, since her diagnosis. For the last several weeks, she's had more pain in her abdomen, and a recent CT scan found that the tumors in her liver and her abdominal wall, which is also called the omentum, are enlarging. Her oncologist or her cancer doctor has referred her to palliative care. Mrs. Jones is wondering, well, is palliative care right for me? And I want everyone who's on to do a little bit of a thought experiment and to think about like what comes to mind when you hear the term palliative care. Or maybe even if you could imagine telling your friend, if you were trying to describe what's palliative care, think about how you would try to describe that to maybe a friend or a work colleague. And while you're thinking about that, I'll show you if you Google image search. So look at Google and say, well, what does that look? What is palliative care like? Well, if you look on Google Images, you see a lot of these images of a hand holding another hand. And often that looks like maybe a younger person hand holding an older hand. I think unfortunately, a lot of these images are showing kind of all Caucasian hands. And I really hope by the end of the day today that you can see how palliative care certainly while we're happy to both physically and maybe metaphorically hold someone's hand, we offer a lot more than that service. And we certainly want our services to be available to the broad diversity of patients we see in the healthcare system. So, you know, unfortunately, I don't think Google does a great job of explaining what palliative care is today. And that's why we're here to try to help out with that. So again, just reflect on kind of what you think palliative care is, how you might describe it to someone as we talk more, and let's see if we can fill in some blanks there. A common question I think about when thinking about palliative care is, well, how is it different from other services? And one of the ways I like to think about it is that palliative care really works to see the person beyond the disease or beyond the diagnosis. And I think a little turn of phrase that I think about is I would think about the person I'm caring for as maybe a person living with cancer rather than a cancer patient. Now, that's just a slight change in phrasing, but I think it really reflects what we're hoping to achieve uh, in our palliative care services to really focus on the personhood, the human dignity that is behind every individual who happens to have been diagnosed with a difficult illness. Another way to think about this or that we approach this is thinking about really the individual with the illness as well as their family, whether that's family, friends, chosen family, are really in the center of the care that we're trying to provide. And we recognize too that a difficult illness like GIST or a cancer or other serious illness affects multiple domains or aspects of life. It can certainly affect the body and cause physical symptoms. We learned about Mrs. Jones having maybe some worsening abdominal pain, but also there are psychological or emotional symptoms, feeling anxious, worried, depressed, maybe just trouble coping with the stress that comes with managing labs and appointments and all the visits. Some people might experience spiritual or existential concerns. That might be things like, well, why is this happening to me? Or what's God's plan in all of this for having to deal with this diagnosis? And then sometimes there are practical issues like getting care at home when that's needed, maybe needing to get physical therapy to get stronger after a difficult treatment course. In palliative care, we really try to take this holistic approach to address all these different aspects of life that can be affected. Just another way to kind of have an image of this, to think about this, is that, again, we really focus on the person, the people being affected by an illness. And palliative care teams are not specialists in a particular organ. So we don't just focus on the kidney, the heart, the brain, the lungs, or just the cancer. We really try to take a holistic or whole person approach. One of the ways we're different is the way that we try to address all those different aspects of life. And the main difference is that we work as an interdisciplinary team, meaning that you're not just seeing a doctor or advanced practice provider, but our teams are typically composed of doctors and nurses, but also social workers, spiritual care providers, or chaplains. And each member of the team has a unique and special role. So, as a doctor, I might prescribe medications to help treat bothersome symptoms like maybe pain or nausea or anxiety. A lot of the work I do as a doctor is thinking about, well, where is someone in the overall potential course of their illness? And what's likely to perhaps come down the pipeline or down the road? And do we need to think about preparing for future medical decisions? As a physician, I also help to coordinate with other doctors, making sure that both I and the individuals I'm caring for have accurate information about their treatments, the risks and benefits that might be associated with the treatment course they're on. I work together with the social workers in our clinic to help provide emotional support, support to caregivers. Sometimes we're helping to order medical equipment like a walker, a wheelchair, or even a hospital bed at home. And then to talk through financial concerns. We understand how expensive all the care around dealing with a difficult diagnosis can be. I work with our spiritual care providers or chaplains to help provide spiritual support, address those big existential questions that can come up. And our chaplains can often provide prayers or blessings or help provide linkage to other spiritual support. So, really, in working as a team is how we try to provide that unique, different type of care that's holistic in nature and trying to address all the different aspects of life that can be affected. Let's look at this definition of palliative care. And I really like this definition because I think it hones in on the most critical aspects of palliative care and tries to put it all together in a relatively brief definition. After we look at this together, we'll break down some of these components to explain what they mean a bit more. So, the definition of palliative care is specialized health care for people living with a serious illness. As we've mentioned, this type of care is focused on providing relief from the symptoms and the stress of the illness. The goal is to improve quality of life for both the patient and the family. Again, family, friends, caregivers, chosen family. It's provided by a specially trained team, like we just talked about. And palliative care specialists, we work together with a patient's other medical providers and doctors to provide an extra and sometimes essential layer of support. This last point is really important. Palliative care is based on the needs of the individual, not on the prognosis. So it can actually be appropriate at any stage or at any point in a serious or difficult illness and can be delivered alongside curative treatment. So I hope that last point is one that really sinks in because I think it's common for people to misunderstand or think that palliative care is only for people who are really, really sick or only for the end of life. We really can see people at any age or any stage of an illness. Already today, I've said this word serious illness a bunch, and I think that can sometimes be tricky to know what we're talking about. I know when I have like even a minor cold, I feel like it's a serious illness to me. I'm not a very good patient. But in the medical world, when we talk about serious illness, we're often talking about a diagnosis that could be life-limiting. And a lot of the diagnoses that we might see are things like cancer or other major organs that are being significantly impacted by an illness. So, heart failure, liver, kidney, or lung disease, neurologic illnesses like dementia, ALS, or Parkinson's disease. And sometimes we'll see people who have just had to be in the hospital a lot more frequently than they used to be, or they're becoming more dependent on others for their care. So all these diagnoses can be potential good fits to see a palliative care team. Let's go back to Mrs. Jones. And remember, she was asking, well, is palliative care right for me? And she's an individual with metastatic GIST who's been having some worsening abdominal pain. And a recent CT scan had shown that some of the tumors in her liver and in her abdomen were getting a bit larger. So after learning more about palliative care, Mrs. Jones schedules an appointment when the palliative care clinic calls to offer her an appointment. And at her first visit, she meets with a palliative care doctor and a social worker on the palliative care team over a telehealth or a video appointment. And during that initial 60-minute appointment, The doctor and the social worker ask her about her life, her hobbies, her social supports, and they ask her more about that recent pain she's been having in her abdomen. So that's what Mrs. Jones' kind of first appointment with a palliative care team might look like. Let's go back and talk about some of the ways and some of the things that a palliative care team might be able to help with. We talked about those physical symptoms like pain or difficulty breathing, shortness of breath, nausea, constipation, something that can really impact quality of life. Also, those emotional symptoms like anxiety or worry, depression, just coping or stress, sometimes fatigue or exhaustion, low appetite, nerve pain or neuropathy, and then caregiving, helping to be there to take care of caregivers. You might be wondering, well, great to hear about all those things that you help take care of, but how do you actually help? And I think one of the things that palliative care does that can be a little bit different is we do take a holistic approach to treating difficult symptoms. And we know that many symptoms, whether that's nausea or pain, they can be complex. And even the physiology of how the brain and the body um, interpret those signals and make you aware or create that physical sensation that you're feeling is complex. And we think about the treatment also being maybe complex isn't the right word, but at least multiple aspects of a treatment plan. Our treatment plans often include using perhaps medications to treat a symptom, like using pain medicines to help treat pain. But we also try to leverage non-pharmacologic or non-medication treatments, like psychological strategies. So helping to think about how to reinterpret pain signals or how to use like relaxation techniques or visualization techniques to try to help reduce your experience of pain alongside pain medications. Integrative techniques like acupuncture, acupressure, or spiritual practices like meditation, prayer can all be ways that we might try to help address difficult or bothersome symptoms. Let's go back to Mrs. Jones and take a look at her case here. So after learning more about Mrs. Jones, the palliative care team recommends the following. So this is after their initial consultation for a new patient visit. They recommend a new medication to help with the abdominal pain that she's been experiencing. They also recommend joining a local support group for people living with metastatic GIST. So maybe palliative care might refer someone to the Life Raft group to try to find other people living with a similar diagnosis to get extra support. They also have a spiritual care team member follow up with Mrs. Jones. And a follow-up visit is scheduled in 4 weeks to check and see how that new pain medication is working. And a palliative care nurse will call in 3 or 4 days, again, to check on pain control. One of the other things that palliative care can help with is making medical decisions or thinking through potential medical decisions. That might include something called advanced healthcare planning, which can include both conversations about what's likely to be ahead, choosing a surrogate decision maker, so someone who might step in to help make medical decisions if someone isn't otherwise able to do so. Sometimes that can help or can include completing documents, documenting wishes for future medical care, like an advanced healthcare directive or something called a POST form. A lot of times I'm helping people think about how to weigh different treatment options, thinking about what are the potential benefits of the treatment being offered, and what are the risks or the burdens of that treatment, and how can we maybe mitigate some of those burdens. So this is all part of kind of helping with medical decisions. Let's go back to Mrs. Jones. So Mrs. Jones and the palliative care team, they continue to meet regularly over the next several months. During that time, unfortunately, Mrs. Jones' cancer progresses and it spreads, and those tumors grow a bit more despite the treatment that she's getting. The palliative care team continues to meet with Mrs. Jones to talk about those benefits and burdens of continuing treatment and just tries to help her think about other options. When I was speaking earlier and reading that definition, we talked about palliative care as being an extra and essential layer of support. And I just want to highlight that seeing a palliative care team does not mean that you're giving up any treatment or any of the other aspects of your care. It really is added on. It's extra support. So when people see a palliative care team, they are still seeing their cancer doctor or their oncologist. They continue to see their primary care doctor. There's no treatment, imaging study, lab test that isn't available while you're seeing a palliative care team. This is, again, just extra and added support. And we really do work collaboratively with the other care team members to make sure we're trying to coordinate and come up with the best care plan. That last point in that definition of palliative care had mentioned that palliative care can be appropriate at any age or any stage of an illness and alongside curative treatment. And I think that's really important to know. And when I'm in clinic, I might see someone who's newly diagnosed with a difficult illness, and I'm seeing them to try to help with coping with maybe that initial shock or trying to figure out how to provide and plan ahead to have additional social supports that they might need in their house. I see people who maybe are cured of their underlying illness, but they still have difficult symptoms, maybe as a result of treatment or some of the residual damage that could have happened from an underlying illness. We see people who, again, could be cured of their illness, and even people who can't be cured, but they're still undergoing treatment to help improve their quality of life, to prolong their life. We see those individuals as well. And of course, we continue to see people who maybe can't get treatment for their illness anymore, but we're still working to try to improve that quality of life. We can always work to try to improve that no matter what's happening with the underlying illness. I think another reasonable question to be asking is, well, does palliative care work? Is it actually helpful? And fortunately, we've had quite a bit of research that's been done to look at the benefits of palliative care. And this study is now about 15 years old, and it was remarkable in showing that when patients with cancer, and in particular in this study, it was patients with metastatic lung cancer at the time they were diagnosed, when they got set up to see a palliative care team from the very beginning and to meet with that team on a regular basis, those patients actually lived about 2.5 months longer than patients who didn't get palliative care or got palliative care maybe whenever their oncology doctor normally would have recommended it, which often could be quite late in the course of an illness. So this was really groundbreaking evidence that was surprising to a lot of people to show that being connected to a palliative care team actually could help you to live longer. This finding has been replicated in several studies. I think there's still some debate and research going on about why exactly this is the case. But I think this is important data to share with people to know that palliative care does not mean that your life will be shorter in any way, shape, or form. In fact, it could help people to perhaps live longer. Many studies have demonstrated other benefits to palliative care, improving quality of life, better symptom control, improved psychological outcomes like spiritual well-being, fewer distressing psychological symptoms, and greater satisfaction with care. People who see palliative care also often are able to be hospitalized left, or if they are in the hospital, to spend fewer days in the hospital. And caregivers, family members, also report feeling less burden when they have the support of a palliative care team. So those are some of the major benefits that we've seen with palliative care. I've been talking to you all quite a bit, and I'd love to take a little break here and pause to have another patient who received palliative care tell more of their story.
The best thing about palliative care for me, and I think for every patient, is You have an objective.
I'm not hearing that on my end, so I'm a little bit worried that you all may not. Give me
Oh,
just 1 second to see if I
we
can.
we can hear it, but it might be a little slow.
Oh, okay. I will put this back on and just let me know, Sarah, if you're having trouble hearing it.
Supportive team that is there to help you live through your cancer. Your oncologist treats the cancer, has your best interest all the time, but there are issues that are a result of that treatment that you need help with, and that's what palliative care has really done for me. My name's Larry Gershon. I'm 75 years old. I love being outdoors. I love being with family and friends. I love traveling and reading. I had a really bad cold, and frequently throughout my life when I have a bad cold, it went into asthma symptoms. I went into urgent care at a local health facility and got treatment for the asthma symptoms. And before I left that appointment, the urgent care doctor said, I want to do an x-ray to make sure you don't have pneumonia. And the next day I got a call, and fortunately I didn't have pneumonia, but I did have a spot on my upper right lung. And diagnosis was stage 4 lung cancer. It was shocking, it was disturbing, it was unsettling. I knew about palliative care. I was a little resistant initially, but I also knew that palliative care was very beneficial for lung cancer or any kind of cancer patient. So I stuck it out, and soon it became apparent to me that my life was better with palliative care. Going through 10 years of life with any type of cancer disease has its inherent challenges. And I think over time, I didn't really realize the stress that was happening. And palliative care initially was really beneficial to me to help balance that life and existing with cancer. It helped me normalize my dealing with cancer, to be able to focus on cancer when I needed to, and the rest of the time enjoy life to the fullest. The palliative care team helped me talk through treatment on several occasions. I had new cancer on several scans during the last 3 years, and until recently I chose to deal with those by radiating them. And palliative care helped me talk through that decision process, feel comfortable with it, understand what it meant to do that, and what it would and wouldn't do for me. But it helped me talk through that process and be comfortable with my decision. I'd like to share with anyone who doesn't know or doesn't want to know or doesn't want help from palliative care that it's a real benefit. Patients may not realize they need it, but and they may be afraid to go to palliative care because they have a preconception about the stigma of end of life. But palliative care is so much more than that. It really helps a person live in a very difficult situation.
All right. Hopefully that was helpful to hear a little bit more about Larry's story. And sorry if there was a little bit of a lag in the audio and the video there. But hopefully that was just helpful to hear. And I think it was nice to highlight how palliative care was really helping him think through what his treatment options were to support him in his medical decision making and follow him over time. A lot of people might wonder, well, when is the right time to ask for palliative care? And I think if you're living with one of those serious illnesses that we discussed, if you're having difficult symptoms, facing difficult decisions, or having difficulty coping, those might be signs that talking with a palliative care team could be helpful. I think that our team really shines because of that interdisciplinary team that we have, the doctors, nurses, social workers, and spiritual care providers, that when you're starting to feel that multiple components or big aspects of life are being affected, like the mind, body, spirit, that's when our team really shines because we work together to try to help address those holistic concerns that are coming up. Some people wonder, well, how do I bring this up to my other doctors? And sometimes we recommend this wording to say something like, I wonder if palliative care might be a good extra layer of support for me. Would you be willing to refer me to palliative care? Or maybe you already have something in mind that you know you'd like a little bit of help with. So saying something like, I'd like to get some additional support for my abdominal pain, and I'm wondering if a palliative care consult might be helpful. You can even use this presentation as a good excuse. Hey, I went to a talk by this palliative care doctor. Do you think it could be something that could be helpful for me? So if you're interested in palliative care, talking to your current team is probably the best next step. Some people wonder about who pays for palliative care, and in general, across the country, it's covered by insurance like pretty much any other medical specialty. So if you have a copay when you go to see your oncologist or your cardiologist, you might have a copay when you see palliative care. Um, but it typically is covered like other medical specialties. I know people are joining from around the country. Here in California, there's been even some more legislation to improve access to palliative care for those who have insurance coverage through public insurance. And I know even for my own insurance plan, I was curious how I might try to find a palliative care team. And I went into my insurance portal and searching palliative medicine or hospice and palliative medicine or palliative care, I could see those search terms would find the right doctors who had the training and are part of the palliative care teams that we're talking about today. So those are hopefully some tips for you to help look into getting connected to a palliative care team if you feel like it could be helpful for you. Again, how to access this, the best thing to do is to talk to your current medical team and to ask for a referral. Referrals can typically be placed by a primary care doctor, your other primary specialists like an oncologist. It's important to note that sometimes palliative care is called supportive oncology, and the name can be different between different institutions. But I would hope that your current team would be able to help connect you and point you in the right direction. I will say that a lot of my colleagues are also still learning about palliative care and may hold some misconceptions. So if it's something you think will benefit you, please be insistent or even provide a little bit of the education from what you're learning today back to your provider if you're feeling that maybe they're having some resistance in making that referral. In preparing for today's talk, we really appreciated the Life Raft group had helped send us some information about questions that were being asked. And I wanted to mention some of the services that we work with and that we're often collaborating with that are separate and distinct from palliative care. Again, palliative care might be called supportive oncology at some cancer centers. And these are some other services, though, that are in existence that might work collaboratively in addition to palliative care. So integrative medicine, or sometimes called integrative oncology. Sometimes this is called complementary and integrative medicine. These are teams and practitioners who are experts in complementary alternative medicine. That might include like herbals or supplements, acupuncture, acupressure. In our palliative care team, we sometimes refer out to acupuncturist or Ayurvedic or traditional Chinese medicine. Often these fall into the category of integrative medicine or integrative oncology. In my experience, there can be some variability in how available and how covered these services are by insurance. So it's good to check locally about what services are near you. Home health is a service that's often covered by insurance and typically widely available. Often home health services can include like a nurse coming to visit you at your home, physical therapy, occupational therapy, or social work. Typically, to qualify for home health, an individual needs to either be homebound or to have significant difficulty leaving their home in order to have those services covered by insurance. But often palliative care, we're working together with home health agencies or ordering or referring our patients to home health if they have mobility issues and need some extra support at home, like a nurse helping to check in on their medications. Survivorship programs are sometimes in conjunction or separate from palliative care teams. And that's really to help support people in remission, on surveillance, or maybe cured of their underlying illness. And those programs often focus on managing the physical and psychological symptoms that can still linger even when the cancer or the underlying illness is really under control. I know there can be variability in the availability of these programs, but typically if they're part of a medical specialty program, they would be covered by insurance like palliative care is. So I hope that helped just distinguishes some of these other services that work alongside, but may be somewhat distinct from palliative care teams. Another service that is distinct from palliative care, but related, is hospice care. And I really like this image. It's the one that I kind of hold in my mind when I think about how palliative care and hospice are related. I think of palliative care as this kind of umbrella term and this umbrella service that focuses on improving quality of life, but really can be available for people at any age or any stage of an illness. Hospice is a form of palliative care that really is care that is focused on care at the end of life. So let's talk a little bit more about exactly what hospice is. I think that will help distinguish it from palliative care a bit more. When I think about hospice, I often think of it as these three things. It's a philosophy of care, it's also an insurance benefit, and then there's a set of services that come with hospice. As a philosophy of care, I think of hospice as being really comfort-focused care. What I mean by that is that often when people are a good fit for enrolling in hospice, their number one priority in their care plan is to focus on being comfortable. And that means that really their care team and they will think about everything happening to and for them. So whether that's a lab test, a medicine, an intervention, the question they'll be asking is, does this help someone to feel more comfortable right now in this moment? If the answer is yes, that's something that probably hospice would and should be doing, like providing medications to treat pain or shortness of breath. But if it's an intervention that isn't helping make someone more comfortable in the moment, it's an intervention that hospice typically wouldn't continue to provide. Hospice is often delivered where someone wants to be and where they can be most comfortable and their needs met. For a lot of people in the United States, hospice is delivered at home. So hospice is rarely a place that you go or an institution that you go to get hospice. A lot of hospice is home-based care. As an insurance benefit, hospice is covered by nearly all insurance plans, including Medicare and Medicaid. And it's the insurance that provides eligibility guidelines, really stating that two doctors need to agree that someone's prognosis is likely to be 6 months or less to be eligible for hospice services. Because hospice focuses really on that comfort piece, it typically does not cover cancer-directed therapy. So most people who are enrolling in hospice are choosing to also stop their chemotherapy or immunotherapy and really focusing just on the things that will help them be comfortable. There can be discussion about specific treatments when someone is transitioning from kind of cancer-directed care to more of a comfort focus. So something that's good to talk about with your current care team or a hospice agency. As a set of services, hospice can be a little bit similar to palliative care in that it includes an interdisciplinary team that can include a doctor, a nurse, social worker, chaplain. There are also volunteers and home health aides that work with hospices. As we mentioned, it's primarily home-based care, if that's where someone can be most comfortable. A big benefit is actually there's a 24-hour nurse call line so that if it's 3 a.m. and there's an issue, there's a phone number you can call and get a real live nurse to give you advice over the phone for how to try to help manage the issue that's coming up. If that advice over the phone isn't working, hospices often can send a nurse to the home to do an assessment and help make further recommendations, often being able to send that nurse within 24 hours or so. Hospices sometimes can help transfer someone to a nursing home if their care needs are greater than what can be provided at home. Although hospice doesn't provide the costs associated with the room and board of that facility, but they do prescribe and provide all the medications that are needed for symptom relief and provide medical equipment like a hospital bed, wheelchair, or bedside commode. Hospice does not provide 24-hour care. So if someone is in the home and they have sort of care needs throughout the day, those are often provided by friends, family, or potentially through private caregivers. So that hopefully gives you a little bit of a sense of hospice as a service. Having talked about all that, let's go back to talk to Mrs. Jones. You might remember she was last thinking about and weighing the benefits versus the burdens of her current treatment plan. And after continuing treatment for several more months, so Mrs. Jones continued on her treatment after that last visit, but Mrs. Jones just really started to decide that the burdens of getting treatment was no longer worth the decreasing benefits that that treatment was having on the cancer. So her treatment wasn't keeping the cancer under control. It continued to grow. She met with palliative care to talk about her goals, and her goals at that time were really to be comfortable and to try to stay at home and manage her symptoms without having to go to the hospital. So at that time, palliative care helped make a referral to a local hospice agency, and Mrs. Jones decided to enroll in hospice. So I think in following this case of Mrs. Jones, we really saw how she came to see a palliative care team who helped her to manage physical symptoms, to get connected to local resources for social support. She continued treatment for many, many months, and palliative care was just supporting her, helping her think through her treatment options. And at some point, unfortunately, her treatments were not providing the benefits that they used to, and helped make a transition to a hospice care plan and to a hospice team. I wanted to provide a few resources for you. And again, I know that people are joining from kind of all over the country here today. So I won't spend much time on our palliative care team at Stanford. For those who are in the Bay Area, we have a lot of palliative care teams throughout the Bay Area. For anyone in the country, this website, getpalliativecare.org, is a great resource where you can put in your zip code and search for a palliative care team near you, including hospital-based palliative care teams, office or clinic-based teams, and even home-based palliative care. So I really recommend, if you're thinking about getting connected to a palliative care team, you of course can ask the current medical team members that are helping take care of you or your loved one. And you can go to getpalliativecare.org to search for palliative care teams in your area. Here are a few more resources to find out more about palliative care. We have some educational information on our website through Stanford. Palliativedoctors.org and caringinfo.org are both public-facing websites that help provide information. And again, that getpalliativecare.org to find a palliative care program near you. As we wrap up here, before we transition to kind of taking questions, just to say that if you're facing difficult medical decisions or difficult symptoms, palliative care, we're really here to partner with you to try to improve quality of life and navigate those decisions. And perhaps we can wrap up with another patient story, this time highlighting a caregiver who worked with palliative care. And I'll play this for you, and then we'll transition over to hearing more of your questions.
The best thing about the team is that they are clinicians, but they don't feel like clinicians. They feel like people who are advocating for us, who really want to help us and have the time to help us. In a word, I would describe palliative care as our dream team. My name is Sherilyn Taylor. I'm from the East Bay, Oakland area, grew up, born and raised here in Oakland. My mom is now a 59-year-old woman with young onset Alzheimer's disease. She was a very strong woman initially, pretty much a go-getter. She was a strong, single mother, hard worker. She worked with the elderly. She wanted to give back to that population of people because she's always been a caregiver herself. Just seeing her decline over the years with not understanding that she had dementia was challenging for me. She was living at home, but the level of care she needed was more than we could provide. When I first heard about palliative care, I didn't really think too much into it. It wasn't until later on, after hitting a lot of roadblocks and just a lot of closed doors, that palliative care resurfaced itself again for me. Palliative care helped us because after all the resources that our primary care gives us, after just trying everything, I was just completely stuck. We hopped on our video visit. It was really easy. It was myself, my mother, my family, a social worker, the doctor. The team there took their time. They combed through her chart with a fine-tooth comb and listened to me. It was actually the first time that I felt completely heard and supported. It was the first time that I reached out to a team or was connected with a team that really 100% wanted to help me. The team helped us talk through the levels of care that she might need. It's really hard with Alzheimer's to know which stages we were in, but based on symptoms, based on her chart history, the doctor determined at that time that my mother would need a higher level of care. I would say the symptoms that palliative care helped my mother with was just peace of mind, if I could look at it from an outside perspective. Being that she can't really speak and express, I could feel the shift and the change in her energy after we were able to get her the help that she needed. For myself, the symptoms that palliative care helped me with was just the high level of stress, depression, and anxiety that I was feeling every day with my family. And palliative care helped me by holding my hand and walking me through those doors and allowing me to see clearly without the frustration and the fog of just challenges and emotions that come along with being a caregiver and navigating the healthcare system. And to see myself now in her shoes, kind of carrying that torch for her and advocating for her in this way. She cared for my grandmother. She cared for my aunt. She was a foster parent, and she's always cared for other people. So it's only right that I give that back to her because it's what she deserves.
All right. Well, hopefully it was helpful to hear another perspective from Sherilyn, from a caregiver point of view. And with that, perhaps we can move on to take some questions from the audience. I'll just share, if you are interested in signing up for our quarterly newsletter to learn more about some of the educational offerings we have, you're welcome to use this QR code. Or if you're part of another group that you think might be interested in this content, you can also use the second QR code here and request a session from our team. But let's see if there's some questions.
Amazing. Thank you so much. This was a fabulous, comprehensive presentation, and I think those videos were really helpful as testaments to the power of palliative care. There's been some questions in the chat. I could repeat them if that's helpful. Just if you, or people can just read them on their own. But just to maybe kick off, we have heard about the role of surgery in life prolonging rather than curative intent, and how there are surgical oncologists who also work in palliative care. And just wanted to hear your thoughts on the role of surgery in palliative care, and that just like a follow-up question that somebody had on, are curative and palliative care completely different?
Yeah, great question. So a couple things come to mind with that question, Sarah. One, I think, is just to acknowledge that sometimes the word palliative is used to describe chemotherapy or even a surgical procedure too. So just to acknowledge that sometimes when that word is used, like a palliative surgery or palliative chemotherapy, it often is actually referring to like the goal of that chemotherapy or of that procedure is maybe not to necessarily totally cure an illness, but to try to help improve the quality of life of the individual or to help someone to potentially live longer, but not to completely cure the illness. That is different than especially palliative care, seeing a palliative care team, where in fact we do sometimes see people who could be cured of an underlying illness. So I just want to sort of clear up that use of the word can be a little bit different in different contexts. In terms of sort of surgical interventions, we would work together with surgical oncologists. And if a surgical oncologist felt that there's a surgical intervention that could be helpful to improve quality of life, to help someone to live better and longer, we would certainly support patients in going through that procedure and would be happy to talk with them about like the benefits versus the burdens of the procedure. Um, and there may be surgical oncologists who also practice specialty palliative care in addition to their surgery practice. We don't have someone like that here at Stanford, but I could imagine that being the case because they certainly do a lot of kind of what we might call primary palliative care in surgical oncology, like helping to manage pain or other symptoms. Um, what we've talked about today, we would really call specialty palliative care, where you're meeting with someone who's specially trained, got extra training in addition to their normal medical training to do this type of care, to manage difficult symptoms and help with that care planning. Did that help answer the question, Sarah?
Thank you. Is there ever a reason why a doctor would not want to help get a referral for palliative care?
Yeah, that's a great question. I'm biased, obviously. I would say that should be no. And what I would say is, in my clinical experience, I do think that very well-intentioned colleagues of mine are still learning about palliative care too. In the grand scheme of medicine, palliative care is still a relatively new field. And some other physicians and colleagues may also hold the misconception that palliative care is just for the end of life. And I hope today the biggest takeaway is that that's not exactly the case. And we really want to help people all along the spectrum of an illness. So I think that if someone is sort of saying, I don't think you're ready for that referral, a little bit of education saying, well, I get that I'm maybe not at the end of life, but I'm dealing with this like difficulty coping with the diagnosis and a lot of anxiety from this disease. I'm really looking for some extra support and help. So I think being specific with kind of what you're hoping for might help to sort of shift the frame that that other person you're talking to is thinking about, and providing some of the education that you learned today might help them. But I really hope that as time goes on, there's less and less resistance that people meet when they're asking for palliative care, and there's more proactive referrals to our services from those primary specialists dealing with the underlying illness.
Thank you. The last case you gave was of a caregiver, and I was curious if you could provide specific strategies that have been effective to help with caregiver burnout.
Yeah, I think one thing is just to identify that if you're providing caregiving, that you are a caregiver, and to acknowledge that that can be a very difficult task. And there are a lot of resources available to help support caregivers in health institutions, in community-based organizations. One thing I try to tell the individual I'm working with who are caregivers is to try to remember too that often caregiving is a marathon and not a sprint. And if there are opportunities, or if there's a way to build in some form of self-care, relaxation, taking a break, having another family step in for a few hours to let you take care of yourself, that is caring for your loved one. Caring for yourself is so critical. On the healthcare side as a provider, we need you. We need you to help support that loved one and for the long haul. And that means you've got to also take care of yourself, and prioritizing your needs is just as important as taking care of your loved one too. It really is a dual relationship between caring for yourself and caring for your loved one. So that's a small piece of advice. And it's something that our team can dive into more.
Yeah, thank you. A question came in about if a person is receiving treatment at one facility, can they get treatment from elsewhere, like palliative care elsewhere?
Hmm. That's a good question. And I think in theory that may be able to be possible. Um, I do recommend in general that if you're able to keep your care at a single institution, if all, for example, if all the services that you need are provided there, that can be helpful just for that care coordination piece. But if, for example, you were at one healthcare institution and they didn't have palliative care and you wanted to see a palliative care team, you might need to go to a different institution to get that. And I think that you should ask for that, and that should be able to be available to you. But I do think for care coordination, if possible, staying within one healthcare institution, I do think helps make things a little bit better coordinated and can help make the communication between your medical teams a little bit easier.
There's still some time for questions if people still want to type them into the Q&A. We had some answered, but they also were covered in the presentation as well.
Maybe I'll pick up a question here of how long can a patient stay in palliative care? Some people might worry like, well, I don't know if I really need palliative care just yet. Is it going to be like a waste of time? What I would say is that, you know, let's meet. It's very flexible. So some patients I might see every month for several months and then we space things out. Other times I might do a consultation and it's almost like just a little tune-up and we may not see each other again for 6 months. So that kind of follow-up and how closely we might follow each other really depends on the individual needs. And I don't think that people who are asking for palliative care need to stress too much about like, oh, is this going to be like a big burden? Is it going to be too much or too little visits? That's something that's often negotiated between a palliative care team and the person and family they're caring for to kind of figure out what's the right fit for what you're looking for and what we have to offer. And that's true for how long we might follow someone too.
Amazing, thank you. Anything else from the questions that submitted that you want to build off of? Because I don't think any other questions. Oh, question. Oh, couple new questions have come in. How does palliative care treat pain management, and does it deal with addiction issues?
Such a great question. And I would say that the intersection between serious illness, pain medicine, and pain management and addiction is one that is evolving over time. Our team at Stanford will try to help with pain management even when there is sort of an addiction related issue. And we do have addiction medicine specialists that we might work with. So I would say that that is a potentially, and it may really depend on sort of like the local institution, local resource practices. But I will say, big picture, this is an evolving area that people are acknowledging more and more needs attention. We know that people with serious illness, fortunately, are living longer, which is a great thing, but it also means that kind of using some of the medications and some of the complications around use, misuse, addiction can also come up. So we're working as a field to try to take better care of folks with this. And I know our palliative care team will take those cases on, often in collaboration and coordination with an addiction medicine team.
And just real quick, because we're going to have to transition to the Spanish version of this webinar, would a palliative department ever refuse a patient?
It's a good question. And again, I think the local resources are really, things can be different between one team and the next. I know here that there are some people that we wouldn't necessarily take on their case. For example, if someone had chronic low back pain and they're seeking help with pain management, but the pain that they're experiencing isn't from a life-limiting or a serious illness, that person probably wouldn't be best served by our team because our expertise isn't in chronic pain management. It really is in symptoms or pain related to an underlying serious illness like cancer. So we would really have those individuals be seen by like a chronic pain specialist. So sometimes there might be a referral that comes to us that just we may not be the right fit, and we try to redirect that to a place that we think would be most appropriate. That's what I've seen here, but again, I think local variability a little bit.
Thank you so much, Dr. Smith, for your time today. A wonderful presentation. This is recorded. It will be up on our YouTube channel, and we'll circulate that. Thank you, Anne, for also chiming in, answering questions. And everybody, thanks for your time today. Have a wonderful day.